Next, we'll have Charlie Thompson come up to the podium and give a talk about challenging our assumptions about the way we manage asymptomatic non-visible hematuria. Charlie, he's a consultant renal physician in Newcastle, as I think I mentioned, and a good friend and colleague.
Thank you very much for the invitation. I'm not sure why I accepted it, except it was a long time ago, but I hope to be able to entertain you. What would good evidence look like in deciding whether or not to investigate with urological investigations people with asymptomatic microscopic hematuria? Well, I think it would look something like this. You'd take people with that condition, detected by screening or detected for some reason other than symptoms, and you'd randomise them to watchful waiting or to cystoscopy and upper tract imaging, as you do at the moment. And then we'd find out what happens. And the primary outcome would be death from cancer or the need for surgery for cancer, and there'll be secondary outcomes including quality of life, harms caused by investigations, etc. We certainly don't have that level of evidence. In fact, we don't have much evidence at all. Tim Porter and I reviewed the evidence 15 years ago, and in my revisions for this, unless I've just missed swathes of new literature, there isn't much new since we published that BGUI article at that stage. There are some relevant guidelines, despite the absence of high-quality evidence, and that is a good illustration of the conflict between guidelines and evidence. So the NICE cancer referral guidelines, which I understand are being updated, but at the moment this is what they say, suggest that people over 50 with asymptomatic microscopic hematuria should be sent to a one-stop urology clinic to look for cancer, and people with a raised creatinine or proteinuria should be sent to a nephrologist. They don't actually specify what to do if the renal investigations are negative, but it's a fairly simple algorithm to follow. Of course, most people don't follow that and refer people at a much younger age than 50 for those investigations. The NICE chronic kidney disease guidelines, revised in 2014, refer indirectly to the need to prompt investigation for urinary tract malignancy in appropriate age groups without specifying what they mean, but I assume that they mean 50 because that's the NICE guideline. The way NICE guidelines don't really join up between specialties is an irritant for lots of us, I'm sure. The NICE guidelines also go on to say that patients' wishes and comorbidities should be taken into account when considering referral, and I'm sure that GPs mostly do that. And they say that people with CKD in the following group should normally be referred for specialist assessment, and one of the most important criteria for the assessment for the referral of people with asymptomatic microscopic hematuria is an albumin-creatinine ratio in the urine of more than 30 milligrams per millimole, which is so-called microalbuminuria, but I'll show you later is a pretty good guide to the fact that the patient has a bad renal prognosis. That's seldom done in my sample. I don't see many referrals coming from the one-stop urology clinic where the urologists have reliably done an ACR as part of the workup, whether or not the cystoscopy was negative or positive. We do have joint BAUS Renal Association guidelines that are developed at my instigation when I was chairing some committee or other some time ago. I wasn't involved in their genesis, apart from instigating that, and they use the age cutoff of 40. They don't give an evidence base for that. It's profoundly unhelpful because now every GP in the land doesn't know what to do between the ages of 40 and 50, and they write to us for advice, and there's a huge exchange of correspondence about whether or not a 45-year-old should be sent or not sent to whichever clinic. They also make the very unhelpful statement that if you have a blood pressure of greater than 140 over 90, that's prima facie evidence of kidney disease and needs to be referred to a nephrologist. Hypertension is becoming increasingly common, particularly in immobile and overweight people, and we don't really think that there's much evidence that a blood pressure of 140 over 90 is a good guide to the presence of treatable kidney disease. It's a good guide to the presence of treatable risk factors, namely sedentariness and overweight and other risk factors for hypertension, but it doesn't necessarily mean that those patients will benefit from a nephrology assessment. So in my view, these guidelines are based on poor expert opinion. In that context, but in other contexts, they're relatively straightforward. They don't quite say what you should do to a patient whose urological investigations are negative if they're less than 40, or greater than 40 rather, but it does say in the text that those patients should then be referred on for nephrology assessment. So the relevant questions are, is urinary tract cancer any more common amongst people with asymptomatic microscopic hematuria than in people without? And I won't read the rest of the questions, because I'm going to try and answer each of these questions in turn in the next few minutes. So is urinary tract cancer any more common? Well, there aren't many studies of this. They're difficult studies to design, but this is the best study that I can find. It comes from a low-impact journal, which I've never read before or since this article. But the article took a large population of insured people, insured with Kaiser Permanente, which is a bit like a National Health Service, but not quite, in San Francisco in 1980. The details of the study are there, but effectively they had nearly 20,000 patients without dipstick hematuria on a personal health check and 588 with hematuria, and then they had a group of people with hematuria who had a good reason to have it. And the findings are here. So there were just as many cancers amongst people with no hematuria as amongst people with hematuria over 3 years of follow-up with pretty good ascertainment rates. These are the relative risks, or the crude rates rather, so 1.5 in people without hematuria, 1.5 in people with hematuria. The relative risk after full adjustment was slightly higher, but the confidence intervals cross 1. So there's no good evidence that you're more likely to pick up hematuria by cystoscoping people with asymptomatic microscopic hematuria than you would be if you rounded up a random selection of the general population and scoped them. I'm happy to be challenged on that because I'm anxious. I haven't done my homework very well. Somebody may have published the relevant paper, but I couldn't find it. So what about turning the question on its head? How common is asymptomatic microscopic hematuria amongst people who happen to have a cancer but don't present in that way? And actually, it's not very common. It's about 35% of people. This large study, which we reviewed in our BJUI paper, took 46,000, best part of, people who'd had a scan for one reason or another, and they found 35 renal cell cancers. All of those cancers, apart from those with, presented with symptoms, were found in people without hematuria. So hematuria is certainly not a good way of increasing your pickup rate for urological cancer in the upper urinary tract. The yield from hematuria clinics is around 2.6% if you take people who are screened for the presence of hematuria, and around 4% if you take people whose hematuria is detected for reasons other than urinary tract symptoms during a medical encounter. So you pick up that rate of cancer. And those are from the American guidelines, and it's a pretty good literature review. The incidence of cancer amongst people who decline one-stop hematuria clinics would be a really, really interesting question to answer, and it must be answerable by somebody in this audience just going through their database. So there's a gift for a registrar. That's a paper for you. All you have to do is find out the people that decline investigations for one reason or another and find out what happens to them. Do they die of cancer more frequently than people who have their investigations? We don't know. Does the earlier detection of urinary tract cancer by investigation of asymptomatic microscopic hematuria lead to better outcomes? Well, we have no data on that. We would need to account for lead time bias, and we would need to know how long the lead time was, and we need to do randomized studies of that. And nobody's going to dare do that, I shouldn't think. And actually, the guidelines make it difficult to do the randomized controlled trials that would be necessary to generate high-quality evidence. So that's one example where guidelines stifle the generation of new evidence, or could do if they're allowed to. The lag time between hematuria, asymptomatic invisible hematuria and visible hematuria would be a really important question to answer, because everyone's going to get scoped if they start peeing blood and seeing it. And we don't know what that lag time is. The evidence is that there can be as little as a 3-month lag time between the development of hematuria for the first time and the diagnosis of cancer, but the papers there don't say how the cancer was arrived at, and they're not all necessarily got macroscopic hematuria. So it certainly can have a short lead time. As for which patients should come to us, well, I freely admit before anyone challenges me on that I don't have randomized controlled trials showing that people with asymptomatic hematuria should be referred to nephrologists if they have certain other conditions. And I formed my interest in this when I was made to do a whole series of renal biopsies in people with hematuria and not much else wrong with them at all, in a centre where they were particularly interested in IgA disease. And I still think that it was close to the boundaries of ethics to stick biopsy needles into the patients to find out whether they had IgA nephropathy in that setting. The only treatments that we have that are of any proven benefit are amongst people with relatively rapid progressive deterioration in kidney function or proteinuria, or both, and they often go together. So there's only any justification in subjecting people to risky investigations in patients who fulfill that bottom criterion of relatively rapid progression and albuminuria. We don't have any other treatments. We can offer people a diagnosis, and there are clearly rare but important instances where people need to have a diagnosis for the purpose of insurance or employment, where it might be justified to do a biopsy. This is the incidence of kidney failure amongst Israeli people, I think it's Israeli, with asymptomatic hematuria on routine population screening versus people who don't have hematuria, and you can see there's a big difference in the curves, but look at the scale here, it's tiny. This is 34 versus 2 per 100,000 patient years. So you'd have to treat an awful lot of people, or watch an awful lot of people for a long time with asymptomatic, non-albuminuric hematuria to find a person with kidney failure. If you have blood and protein as well, protein as well as blood, however, the risks are very much higher. This is a real pity, because this study looked at kidney disease in a group of people in Okinawa, Japan. And the one I've looked carefully, they didn't look for urological disease, and there are no reports from this long-term follow-up study using dipstick urinalysis to see how many people got cancer, and that's a big waste, unless I've missed it. We published a review on this recently in the BMJ, and it's there for your reference, and each of these references is on my Twitter feed if you want to find them that way. My view is that the guidelines that BAUS and the Renal Association put together some time ago are ripe for review, and instead of just producing a guideline, we should produce a guide for patients about whether or not to subject themselves to investigation, and that could be titrated by their age, their other risk factors, and their preferences and values of whether or not to undergo investigation. Thank you very much indeed for your attention.